Usually when we talk about a medical diagnosis, there's this expectation of just absolute precision.
Right, like engineering.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points to the film and says, there it is.
Yeah.
That's the problem.
Yeah, we really crave that binary. I mean, we want the world divided neatly into healthy and sick, broken and functioning.
hmm
It just offers a sense of control, right? When a professional can just point to a scan and give you a definitive answer.
But then you step into the world of neurodevelopment and, well, child psychology, and suddenly that x-ray machine is just completely useless.
Oh, totally useless.
We're looking at a diagnostic landscape that is, honestly, incredibly murky. So to set the stage for what we're exploring today, I want you to imagine a scenario for a second.
Okay.
Picture a kid who is just constantly angry. And I'm not talking about, like, a teenager pouting over chores or a toddler having a meltdown in the candy aisle.
Right, something much more intense.
Yeah, I mean, a child who is blowing up, just erupting into severe, intense temper outbursts multiple times a week, every single week for months on end.
Which is incredibly disruptive.
Exactly. And historically, if a parent brought that child into a clinic desperate for help,
Yeah.
the medical field might have slapped a very serious, very adult-sounding label on them.
They absolutely would have.
But relatively recently, the entire approach to that specific kind of child completely changed.
It's a massive shift in how we understand the developing brain. And it is the absolute definition of navigating those diagnostic muddy waters you mentioned.
Yeah.
More importantly, it's a shift that fundamentally changes what happens to these children after they leave that clinic.
And that is exactly what we are getting into today. We have a really fascinating stack of sources for this deep dive.
We do.
Specifically, we're looking at clinical excerpts and school support documentation from a brief titled DMDD, Clinical Assessment and Support in Georgia Schools.
It's really eye-opening stuff.
It really is. Our mission today is to understand this critical shift in child psychology, explore this relatively new diagnosis called DMDD, and then examine how schools right now are stepping up to provide evidence-based, on-the-ground support.
Right.
Think of this as your shortcut to being well-informed on a topic that is literally changing the trajectory of kids' lives.
Because the stakes here are incredibly high. You know, our goal today isn't just to memorize a bunch of complex medical terms.
Or recite DSM codes, please, no.
Exactly. No one wants that. We need to understand the underlying mechanisms. We have to ask why these labels matter so much.
Right, because it's not just a word on a page.
No, the label isn't just a word sitting quietly in a filing cabinet. It dictates a child's entire trajectory.
Wow.
It dictates the pharmacology they are exposed to, the therapeutic approaches they receive, and perhaps most crucially, how the adults in their world perceive their fundamental character.
Right, from their parents to their classroom teachers. Okay, let's unpack this history, because the way the medical rulebook had to be rewritten is just wild. It really is quite a story.
So back in 2013, the psychiatric Bible, the DSM-5, added a brand new diagnosis, right? Disruptive Mood Dysregulation Disorder.
Or DMDD.
For DMDD. And the reason they added it is because the medical community realized they had a massive crisis of mislabeling on their hands.
Yes.
Kids with chronic, severe, non-episodic irritability were being diagnosed with pediatric bipolar disorder at alarming rates.
Yeah, and to understand why this was such a crisis, we have to look at what bipolar disorder actually is at a mechanical level.
Okay, break that down for us.
So the core mechanism of bipolar disorder involves discrete, distinct episodes of elevated mood.
Like spikes.
Exactly. What we call episodic mania, often followed by depressive crashes. The child's baseline mood might be relatively typical, and then there's this stark, undeniable departure from that baseline.
Okay, so to use an analogy, think of classic bipolar disorder like a sudden, severe software glitch.
I like that. Right. The computer is running perfectly fine for weeks, doing exactly what it's supposed to do, and then out of nowhere, the software crashes and the screen goes blue.
That's a great way to picture it. It's episodic.
Right, episodic. But this new diagnosis, DMDD, that's entirely different. That is a hardware overheating issue.
Yes, exactly.
The cooling fan is broken, the internal temperature is constantly running dangerously hot, and adding even a tiny bit of extra processing load causes the whole machine to just shut down.
That distinction right there between a temporary glitch and a constant hardware strain is the perfect way to understand the so what of this whole diagnostic shift.
Because they're completely different problems.
Completely. When you mislabel a hardware overheating issue as a sudden software crash, you are fundamentally misunderstanding the clinical reality of the patient in front of
All
you.
right.
With DMDD, it is a steady state pattern. The child's baseline is irritable. The baseline is angry.
They're just running hot all the time.
They are running hot all the time. And from that elevated baseline of distress, they have these explosive eruptions.
So if the symptoms are that distinct from episodic mania, what were doctors seeing in the 1990s and 2000s that made them use the pediatric bipolar label in the first place? I mean, were they just, like, ignoring the criteria?
Well, not exactly ignoring it. They were observing severe, intense emotional dysregulation.
Okay.
They saw children whose outbursts were so violent or disruptive that they couldn't simply be classified as having a quote-unquote bad temper.
So they needed a bigger word for it.
Yes.
Yeah.
The clinicians needed a label with enough gravity to communicate the severity of the child's suffering
Right.
and to unlock intensive treatment resources. And pediatric bipolar was just the closest available label on the shelf that carried that necessary weight.
Even if it didn't really fit.
Exactly. It was a terrible fit clinically. The rates of pediatric bipolar diagnoses skyrocketed, creating this sort of false epidemic, simply because the manual lacked the precise vocabulary to describe chronic, unrelenting frustration.
Which means the medical community realized they were getting it wrong. And they had to draw some very specific boundaries around what DMDD actually looks like.
They had to.
Because they couldn't just swap one overused label for a shiny new one and repeat the same mistake.
No, absolutely not. The criteria for DMDD in our sources are incredibly strict, specifically designed to prevent overdiagnosis.
Yeah, the guardrails had to be high. We are looking at a highly specific constellation of symptoms here.
So what are those guardrails according to the sources?
Well, the sources outline it like this. First, severe recurrent temper outbursts, either verbal or behavioral, that are totally developmentally inappropriate.
Right.
Frequency matters too. This has to be happening 3 or more times per week.
3 times a week is a lot.
It is. And the baseline mood between those outbursts must be persistently irritable or angry. Furthermore, this pattern has to be present for 12 or more months.
A full year.
And it has to happen in at least 2 different settings, like home, school, or with peers. Oh, and the onset of all this has to be before age 10.
It is an exhaustive list, and every single one of those parameters serves a specific exclusionary purpose.
Okay, hold on. I have to stop you there.
Sure.
Because when you list out recurrent temper outbursts, verbal or behavioral, and irritable mood, my immediate cynical thought is, isn't that just every toddler ever?
Oh, for sure. A lot of people think that.
Right. Aren't we just medicalizing bad behavior? I mean, kids get mad. Kids throw fits when they don't get their way.
Yep.
How do we know this is an actual neurobiological clinical disorder and not just, normal growing pains or a kid testing boundaries?
That is the exact skepticism the psychiatric community anticipated when drafting these rules.
I would hope so.
And frankly, it's a necessary skepticism to prevent over-medication. Let's look at the mechanics of why those specific guardrails exist, starting with that 12-month duration you mentioned.
Okay, why a full year?
Well, a child going through a rough patch, maybe dealing with a parent's divorce, a sudden move, or bullying, they might act out aggressively for a few weeks or even a few months.
Which makes total sense. That's a situational trauma response.
Exactly. But DMDD requires a continuous year or more of unrelenting symptoms. A full year indicates a structural neurobiological difficulty with emotional regulation, not a temporary reaction to an event.
Ah, okay. That makes sense. It separates a phase from a permanent state.
Right.
And what about the multi-setting requirement, the fact that it has to happen in at least 2 places?
That rules out environmental or relational dynamics.
How so?
If a child is only exploding at home but is perfectly regulated, focused, and calm at school and with friends, the dysregulation isn't a generalized neurological disorder.
Right, because they can control it when they want to.
Exactly. It points toward a specific conflict at home, perhaps a parenting dynamic or domestic stress.
Interesting.
Conversely, if they only explode at school but are fine at home, you might be looking at a learning disability where the academic pressure is causing the outbursts.
No.
But with a true neurobiological inability to regulate mood, the dysregulation goes wherever the child goes. It travels with them to the living room, to the math class, to the playground.
Okay, and the age 10 cutoff. Why is 10 the magic number?
It comes down to basic neurodevelopment. By age 10, a child's prefrontal cortex, the part of the brain responsible for logical thinking and impulse control.
The braking system.
The braking system, exactly. It should have developed enough basic inhibitory pathways to stop a full-blown floor-kicking tantrum.
Okay.
If they haven't achieved that developmental baseline by 10, it indicates a divergence in how their brain is wiring its emotional responses.
And if it happens later?
Right. If these symptoms suddenly appear for the first time at age 14, you are likely looking at something else entirely. Perhaps hormonal shifts, substance use, or the early onset of actual bipolar disorder or
Yeah.
schizophrenia.
Wow. So when you combine the 12 months, the multiple settings, the age limit, and the fact that they are fundamentally irritable between the outbursts, you realize this isn't just a kid who is happy-go-lucky all week and just throws a fit over a video game.
Precisely. The baseline state of a child with DMDD is suffering.
That's heartbreaking.
It is. They are uncomfortable in their own skin most of the day, most days. This cannot be a quick label slapped on by a frustrated adult. It requires intense clinical discernment to differentiate it from trauma, autism, or typical development.
And getting that differential diagnosis right completely alters what happens to the child the moment they walk out of the clinic.
It changes everything.
Because the treatment pathways for bipolar disorder and DMDD are fundamentally different. Treating a child who actually has DMDD with bipolar mood stabilizers, it's like trying to fix a house's sparking electrical wiring by calling a plumber.
That's a great way to put it.
You are deploying heavy, complex machinery to work on a completely wrong system.
And the clinical data backs that up, and it really highlights the tragedy of that misdiagnosis era we talked about.
Right.
Bipolar disorder often necessitates pharmacological intervention, specifically mood stabilizers, to manage those discrete manic episodes.
Which are intense drugs.
Very intense.
Uh-huh.
Exposing a developing brain to heavy mood stabilizers carries significant side effect profiles, everything from severe weight gain to cognitive dulling.
Ugh, that's awful.
So when a child with DMDD was misdiagnosed, the system exposed them to those risks while simultaneously depriving them of the actual tools they desperately needed.
Because the proper DMDD diagnosis unlocks an entirely different pathway.
Right.
And the primary tool isn't a pill.
No, it's not.
It's evidence-based psychosocial care. Our sources highlight that this involves parent management training, family-focused interventions, and specifically cognitive behavioral therapy, or CBT, that is adapted for extreme irritability.
It's really important to understand how that adapted CBT actually works. It's not just, sitting on a couch talking about feeling.
Right. How's it different?
The amygdala, the brain's alarm system, in a child with DMDD is highly reactive and overpowers the logic center.
Okay.
So CBT for these children is about mechanical skill building. It involves teaching the child to recognize the physiological wave of anger, the heart racing, the tight fists, the shallow breathing.
Almost like warning signs.
Exactly,
Huh.
warning signs. And practicing alternative behavioral pathways before the explosion happens. It's literally rewiring the neural pathway between feeling distress and acting aggressively.
And the parent management training is the other side of that coin, isn't it?
Oh, absolutely.
It's teaching the parents how to not pour gasoline on the fire. If the child's hardware is constantly overheating, the parents have to learn how to de-escalate the environment rather than engaging in a shouting match that just overloads the system further.
To take that a step further, look at how pharmacotherapy is viewed in this new paradigm.
Okay.
The sources clearly state that if medications are used for a child with DMDD, they are strictly added based on comorbidities, meaning other conditions the child actually has alongside the mood dysregulation.
So they aren't prescribed just for the outbursts.
Right. They are never prescribed based on a presumed bipolar diagnosis anymore.
Got it. And the major comorbidity the sources specifically call out here is ADHD.
Yes.
Co-occurring ADHD is incredibly common with DMDD, and the documentation notes that treating the ADHD well often substantially reduces the severe irritability.
That gets to the heart of the mechanism we were discussing earlier. Think of ADHD not just as a lack of focus, but as a failure of executive functioning.
Which means what exactly?
The executive function is the air traffic control system of the mind. It organizes tasks, filters out distractions, and manages impulses.
Okay, I'm following.
When a child has untreated ADHD, that air traffic control system is constantly failing. Imagine the sheer exhaustion of trying to navigate a school day following multi-step directions, sitting still, ignoring the kid tapping a pencil next to you.
That sounds exhausting for anyone.
Right, but imagine doing it when your brain isn't filtering any of it for you.
That exhaustion breeds profound frustration.
Exactly the point. That friction fuels the chronic irritability of DMDD.
Oh, wow. So they compound each other.
They do. So when a clinician treats the ADHD, perhaps with a targeted stimulant medication, they lower the cognitive load. They reduce the friction of daily life.
Which frees up resources.
Yes.
Yeah.
By freeing up those cognitive resources, the child actually has the mental bandwidth to engage in the CBT and emotional regulation strategies we just talked about.
That makes total sense.
It is a beautifully interconnected ecosystem of care, but it absolutely relies on having the right map to begin with.
Okay, so we have this ideal roadmap. We know DMDD is a distinct disorder. It requires careful clinical diagnosis, and the treatment must be psychosocial first, addressing the whole ecosystem of the child.
Right.
But let's bring this down to reality, because there's a massive gap between the DSM-5 sitting on a psychiatrist's shelf and the reality of a chaotic third-grade classroom.
Oh, a huge gap.
Because these explosive episodes have to happen in at least 2 settings, right? So the classroom is inevitably ground zero.
It is a crucible for dysregulation. You have a child whose baseline is irritability, placed in an environment with constant demands, peer interactions, overwhelming sensory input, and strict behavioral expectations.
It's like a pressure cooker.
It really is. And the traditional school response to a child flipping a desk is punitive suspension, detention, isolation. But you cannot discipline away a neurobiological disorder.
Right. Which brings us to the systemic bottleneck.
Yes.
Because even if a teacher recognizes that a child needs specialized CBT, getting a kid to a clinical therapist twice a week is a logistical nightmare for a working family.
It's nearly impossible for some.
You're talking about wait lists, taking time off work, transportation, and navigating out-of-network insurance fees.
That is the failure point of the traditional healthcare model. The best diagnostic manual in the world is useless if the psychosocial care is structurally inaccessible to the families who need it most.
And that is exactly what the school support documents in our sources address. We are looking at how schools, specifically in Georgia, are actively adapting to solve this bottleneck.
Which is really encouraging to see.
Yeah, the sources feature a program called MentalSpace School, which is essentially integrating K-12 mental health support directly into the school building.
Wow, directly in the building.
Yeah. They are providing same-day teletherapy, dedicated therapist teams for crisis intervention, suicide and violence prevention, and family counseling right where the kids spend most of their day.
What stands out clinically about a model like this is the emphasis on utilizing licensed, diverse, and culturally competent therapists.
Why is that cultural piece so important here?
Well, when we discuss the difficulty of differential diagnosis, separating a situational trauma response from DMDD, or understanding if a behavior is just boundary testing,
Right.
cultural competency is not a progressive luxury. It is a clinical necessity.
Okay, break that down.
A specific behavior or communication style that might look like defiance or aggression through one cultural lens might be completely understood in its proper context by a clinician who shares or deeply understands that background.
Oh, I see.
Without that context, misdiagnosis just repeats itself.
And here's how they are removing the financial red tape, which is, often the biggest barrier to this kind of long-term care.
The finances are huge.
According to the documents, for students on Medicaid, this care is $0 out of pocket.
That's incredible.
They also integrate with a massive range of private insurances, like BCBS, Cigna, Aetna, UHC, meaning families aren't forced into a maze of out-of-network fees just to get their kid a baseline evaluation.
Which removes so much friction.
And the sources also mention that these programs are helping schools meet state compliance mandates, things like HIPAA and FERPA to ensure student medical privacy, and specific state deadlines like Georgia's HB 268 compliance deadline of July 2026.
Right. And the outcomes they're seeing from this model are staggering.
Yeah, let me pull those numbers.
Yeah.
So they report 89% improved attendance,
Wow.
92% reduced anxiety, and 85% family satisfaction.
That's a massive shift. While the specific acronyms and legislative bills vary by state, the macro takeaway here is vital. State governments and educational systems are finally recognizing that localized healthcare is a prerequisite for education. If a child is exploding 3 times a week in math class, the school needs clinical tools, not just a thicker detention pad.
So what does this all mean for you, the listener? Whether you are a parent trying to advocate for a challenging child, a teacher feeling overwhelmed on the front lines, or just someone who pays taxes and cares about how society supports its most vulnerable.
It really affects all of us.
It does. Understanding this shift is massive. Realizing that the infrastructure is finally moving towards same-day clinical intake, thorough differential diagnoses, and coordinated care plans happening inside the school It is a total paradigm shift.
It really is.
We are slowly moving away from the old, punitive model of punishing a neurobiological disorder and moving toward a localized healthcare model.
It creates a unified front. By placing the clinical care where the child already is, a program like MentalSpace School ensures that the teacher, the parents, and the therapist are all working from the exact same playbook.
Which has to be so much more effective.
Yeah, absolutely. The CBT strategies practiced in the therapy session can actually be supported by the teacher in real time when the child gets frustrated during a math test.
All right, let's synthesize the journey we've just been on.
Sounds good.
We started in the dark ages of diagnostic mislabeling, where kids were being incorrectly diagnosed with pediatric bipolar disorder simply because they were chronically severely irritable and doctors lacked the right vocabulary.
Right.
We saw how the medical community corrected course in 2013 with the creation of DMDD, drawing strict, precise criteria like the 12-month duration and the age 10 cutoff to ensure we were looking at a steady-state condition of hardware overheating, not a sudden software glitch.
We then explored the treatment pivot. We saw how the correct label saves a child from unnecessary, heavy mood stabilizers and instead opens the door to psychosocial interventions.
Which is so crucial.
We learned that treating the whole ecosystem of the child through parent training, adapted CBT that rewires the brain's alarm system, and managing executive dysfunction like ADHD is the evidence-based path forward.
And finally, we brought it right to the front lines, looking at how systemic programs in Georgia are dismantling the traditional bottlenecks to that exact care.
Yes.
By utilizing insurance and Medicaid to put licensed therapists directly into the schools, they are removing the logistical nightmares for working families and ensuring the care actually reaches the kids. It's a fascinating story of medical evolution leading to real, ground-level change.
It really is. And it leaves us with something profound to consider, especially when we look at the historical context of that DSM-5 shift.
What's that?
Well, if a child's baseline state of severe chronic irritability can now be understood as a distinct, treatable neurological disorder that requires cognitive therapy rather than an adult-level mood stabilizer or a school expulsion.
Yeah.
How many generations of quote-unquote problem children or disruptive kids were disciplined, isolated, or heavily medicated simply because the medical community didn't yet have the right vocabulary in their manuals?
Man, that's a heavy thought.
It is. It forces us to look around our classrooms and our society today and ask a very uncomfortable question.
Yeah.
What other behaviors are we currently punishing simply because we haven't yet discovered the clinical words to understand them?
That right there is exactly why we do these deep dives. To challenge what we think we know, to look at the mechanics behind the labels, and to see the world a little bit differently.
Absolutely.
Thank you so much for joining us on this journey today. We hope this shortcut to being well-informed gave you a few new perspectives to chew on.
It's been great.
Keep questioning, keep learning, and join us next time. Because sometimes when the diagnostic waters look muddy, all it takes is learning the difference between a sudden software glitch and a hardware overheating issue to finally help a child get the support they deserve.